Welcome to this Medicine Masterclass on pleural effusions. A pleural effusion is excess fluid that accumulates in the pleural space. The pleural space is the potential space between the visceral and parietal pleura. This can result from pleural, pulmonary or extrapulmonary disease. The symptoms. Patients can be asymptomatic with small effusions or can develop shortness of breath, may experience pleuritic chest pain, that's sharp chest pain exacerbated by inspiration or coughing, and may also have symptoms relating to the underlying condition. For example, if the patient has a cough, that might be as a result of pneumonia or tuberculosis. If they have hemoptysis, that might be as a result of lung neoplasia or TB. And if they have ankle swelling, peripheral edema, that may well be nephrotic syndrome or renal, hepatic or cardiac failure. So let's take a case. Mr. Williams presents with shortness of breath. Let's discuss the respiratory findings that we would find. So if this patient had a pleural effusion, on examination, we would take an inspection, percussion, palpation, auscultation approach. On inspection, look carefully for any signs of previous chest drains, aspiration needle marks, and radiation therapy tattoos. They may have bedside supplemental oxygen and may appear clubbed. Here's an example of a radiation tattoo, a very small tattoo which is used to direct radiotherapy beams. The scars are axillary thoracotomy scars, usually very small scars, and these are at the site of where the effusion is in a safe area. On palpation, if the patient has an active pleural effusion, they may have decreased expansion and movement on the affected side. The trachea would be pushed away from the effusion, and they may have a radiation tattoo on the affected side. Percussion would reveal a stony, dull note over the effusion site. And on auscultation, there would be decreased and diminished breath sounds over the affected side, decreased vocal resonance and tactile vocal fremitus, as the sound would not be able to transmit through fluid, and they would have agophony at the superior aspect of the effusion. The supporting evidence and the peripheral findings, if the patient appeared cachectic, you would consider malignancy as a cause of the pleural effusion. Similarly, clubbing, tar staining, hand muscle wasting, and hypertrophic pulmonary osteoarthropathy, that the latter being tenderness over the wrists, would suggest an underlying neoplasia. A lymphadenopathy, the presence of Horner's syndrome, also indicate malignancy. And if the patient has radiation tattoos or hair loss or radiation changes, a monophonic wheeze, this would suggest that the patient is undergoing treatment for cancer. If the patient has heart failure that's causing the pleural effusion, they may have a raised JVP, peripheral edema, and bibasal crepitations. If the etiology of the effusion is rheumatoid arthritis, their hands may have a bilateral symmetrical arthropathy with ulnar deviation of the digits and swan neck deformities and rheumatoid nodules. If SLE was the cause of the effusion, look for a butterfly rash. If chronic liver disease is the cause, look for signs associated with this, including ascites, clubbing, Terry's nails, hand muscle wasting, palmar erythema, asterixis, scleral icterus, a raised JVP, spider nevi, hair loss, and gynecomastia. So a number of unrelated signs forming a diagnosis can result in an effusion. When completing, offer differentials. So the differentials will include a pleural effusion. There may be a transudate or an exudate, and other causes of an effusion or other types of effusion include a hemothorax, a chylothorax, and an empyema. But also consider in the differentials lung collapse or a raised hemidiaphragm or basal consolidation or a basal mass, which can give similar clinical findings. So presenting the case, Mr. Williams presents with shortness of breath. The patient was comfortable at rest, and I believe the patient has signs consistent with a left-sided pleural effusion up to the midzone. On inspection of the precordium appeared normal with no scars noted. On palpation, I noted decreased expansion and movement on the affected side, but there was no evidence of tracheal deviation. On percussion, I noted stony dullness over the left lower chest up to the midzone, and on auscultation, I appreciated diminished breath sounds on the affected side, decreased vocal resonance, decreased tactile vocal fremitus on the affected side, and there was agophony at the superior aspect of the effusion. My differentials would include a pleural effusion, which could be a transudate, exudate, hemothorax, chylothorax, or an empyema, but I would also consider a lower lobe collapse, lobectomy, although I'd expect a scar with a lobectomy, a raised hemidiaphragm, basal consolidation, or a mass. Now, we mentioned that there are 5 key types of pleural effusions: a transudate, exudate, empyema, a chylothorax, or a hemorrhagic pleural effusion. Transudates are those with low protein content, and exudates are those with high protein content. So a transudate is produced through pressure filtration without much capillary injury, whereas an exudate is essentially inflammatory fluid leaking between the cells, causing high amounts of protein to be present in the fluid. A transudate is defined with a protein content of less than 25 grams per deciliter in the effusion, whereas an exudate has more than 35 grams per deciliter. Now, between 25 grams and 35 grams per deciliter, Light's criteria is used to determine whether the effusion is a transudate or an exudate. There are 3 key features of Light's criteria. If the pleural fluid to serum albumin is more than 0.5, is considered as an exudate. If the pleural fluid to serum LDH is more than 0.6, we consider the effusion as an exudate. Or if the pleural fluid LDH is 2/3 the upper normal limit for the blood LDH, we also consider the effusion to be an exudate. Now, transudates are usually bilateral and include things such as failures: heart failure, liver failure, renal failure, hypoalbuminemia, Meigs syndrome, mixed edema. Whereas exudates are usually unilateral, caused by a localized disease process such as a malignancy, an infection, a parapneumonic infection, sarcoidosis, connective tissue disease, pancreatitis, and lobar bronchiectasis, or an asbestos-related effusion. Investigating patients with effusions, blood tests are very helpful. FBC, CRP, ESR can indicate anemia, infection. The white cell differential can help further point to an etiology. Usinase, LFTs, thyroid function, cholesterol, amylase, lipids, TFTs, all of these blood tests can help determine the underlying etiology. Clotting is important, particularly if you're going to perform an aspiration. You need to ensure that the patient is not coagulopathic. Glucose and LDH are also important tests. Blood cultures, aerobic and anaerobic, if there's any signs of infection, endocarditis, TB, would be helpful in terms of determining the organism. A VBG can also help to determine the pH, lactate, and the bicarb to give an overall picture of how unwell the patient is. Imaging, a PA chest radiograph. If the effusion is 300 mils or so, it can be detected on a chest radiograph. It's essentially seen as a dense opacification with an associated fluid level known as a meniscus sign that you can see here in the left lung. There's a blunting of the costophrenic angles, and in advanced effusions, in very large effusions, you'll see a mediastinal shift, a tracheal deviation away from the effusion if there's more than a litre of fluid. And you may also see evidence of the underlying cause. You may see a malignancy. An ultrasound of the chest can be useful in determining the depth and the anatomy of the effusion. Sometimes effusions can be loculated and therefore can be very difficult to drain as the fluid is collected in various pockets. If you're looking for more detail or underlying causes, a CT scan can be helpful, and a bronchoscopy and thoracoscopy can also help in determining diagnosis. The fluid itself needs to be analysed. Assess its colour, the pH, the protein, the LDH content. Send the fluid for microscopy, culture and sensitivities, glucose, gram staining, as well as amylase, and pair these pleural fluid samples to the serum sample so that ratios can be determined. Now, the colour itself, if the effusion is clear straw-coloured, it may be a transudate or an exudate, and by determining the protein content or applying Light's criteria, you can distinguish. If the fluid is yellow and turbid, this may be an empyema or a parapneumonic effusion, and if it's bloody in colour, hemorrhagic, think about trauma, malignancy, or even pulmonary infarction. Cytology, analysing the cells. Neutrophils can be seen in parapneumonic effusions. Lymphocytes can be seen in effusions associated with malignancy and TB. and abnormal mesothelial cells can be seen in mesotheliomas. The chemistry, the protein, as we mentioned, is very important, but also assess the glucose. Very low levels of glucose can suggest very aggressive, active bacterial infections or malignancy where glucose is readily being used by the tissue, for example, TB malignancy. LDH can be raised in malignancy and empyemas, and amylase would be raised if the patient has pancreatitis or esophageal rupture or carcinoma. Immunology can help if rheumatoid factor is present. Think about rheumatoid arthritis as an etiology. Anti-nuclear antibodies may be present in the fluid as a result of systemic lupus erythematosus, and complement levels can be reduced in the pleural fluid if the patient has an empyema or malignancy or an underlying rheumatological condition. So to manage these patients, a holistic patient-centered approach is employed. Using a multidisciplinary team, conservative medical and interventional options are made available. Supportive therapies such as oxygen, hydration, chest physiotherapy, drainage, patients may require repeated drainage, and fluids should be removed slowly. Rapid fluid shifts can result in pulmonary edema, and a needle aspiration or pleural drain depending on the clinical situation. In refractory and recurrent pleural effusions, pleurodesis, either with drugs or with VATS interventions, can be used, such as tetracycline, bleomycin or talc, or thoracoscopic talc pleurodesis can be used for malignant effusions, and refractory cases can be referred for surgical intervention. Thank you for attending this medicine masterclass.